Good to see you.
Good to
You look
see you.
good. Yeah. Yes.
It's in the afternoon in the Belgium.
It's afternoon in Belgium. Yeah, it's afternoon, but bad weather. We have not good weather today.
Hi. Hi, Sergio. How are you? Sergio?
Hello.
Yeah.
I'm fine. In
Yeah,
Brazil.
Yeah, same here. Same here. Hi, Asif.
Hello.
Yeah, hello.
Asif is our technical
Okay.
assistant. He is from the Aris Television company. He will be our digitally helping us.
Where
So
is Mababur and
Can I share my screen to test it?
Yeah. Sajja, please go and check. You still have 2 minutes.
Zoom fake is missing.
Yes, she just mailed me whether she can join. I just said that in 5 minutes.
Okay.
It's okay. It's okay.
Yeah, but it's broken a little bit.
It's broken. Yeah.
It's broken.
It's working.
Yeah, the letters are broken.
it's not very crisp.
Yeah, so Professor Chi Sunfek has joined us.
Yeah.
Hi.
Hello.
Hi.
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 Hi, Sunfek.
Hi.
Not that long time ago that we met.
I mean, this is a good medium where we can see each other and make sure they're okay.
That's
They're
correct.
still the same.
Yeah.
They're still the same. Yes.
Yeah.
Yes.
Absolutely.
Hi.
Hello.
Hi, Dr. Morris.
Yeah, Professor Prakash has joined us.
Yeah.
Hi, Prakash, how are you doing?
Sir, namaskar, sir. Sir, namaskar, sir. Sir, how are you, sir?
I'm
Hello,
very
sir.
well. So very happy to see you.
Yes, sir. I'm also very happy, sir. After a long time, I can see you, sir.
Yes, that's right. Looking forward. Yeah, thank you.
Yes.
Sir, we want to start exactly on 7:30.
So it's already 7 now here.
Yeah, so it's 7:30 on our part here.
Yeah, let's start.
Let's start.
I will have to share my screen to have my presentation. Everybody will do that.
Do you want to check? Professor Tazigna, do you want to check?
I think it is okay. I will do it. Yeah. Yeah. Is it okay?
Yes, it's fine. Fine.
Okay.
Okay, so I think if you can stop sharing it. Professor Tazignan, can you just stop sharing so we can start?
Yeah. It is.
Stop sharing.
Yeah. Is it okay? So, yeah.
But still, we are seeing your screen.
Stop share. Voila. Okay.
Yes. Fine. Thank you.
Yeah.
So, dear colleagues, thank you all for joining today's webinar. And we are going to be live on different platforms like Zoom, YouTube, and Facebook. And I want to thank the speakers and the panelists for accepting the invitation. And I want to thank Aristovision for helping me to arrange this meeting and help on the digital part of that today's webinar.
Bangladesh Eye Hospital and Institute is going to organize a series of webinars on ophthalmology. Ophthalmology Webinar 2020, this 19th and 26th of June, and 4th, 10th, and 17th of July 2020 at 7:30 p.m. Bangladesh Standard Time. Big names, great surgeons, passionate teachers, creative innovators, supportive peers of ophthalmology will be speaking on current trends, topics, managing difficult situations about their innovations. Join the webinar where you will have a chance to hear their thoughts, clarify your queries, and know what goes in their heads and minds.
So again, I thank the speakers for accepting my invitation. Just a little introduction, though none of the speakers need any. Dr. Mare Jose Tazignan, she is the Professor Emeritus Head and Chief of Department of Ophthalmology. She was the President of ESCRS and European Board of Ophthalmology. She is the current President Academia Ophthalmologica International, and she was the Chair of the WOC 2020. Dr. Abhay Vasavada, he is a very well-reputed name in the world of cataract. He has been awarded with Bringhurst Gold Medal Lecturer at ASCRS. He was awarded doctorate by Hungarian University. He has got more than 200 publications in peer-reviewed journal, and he is a PhD guide at 3 major universities. Dr. Chi Sun Fei, she is the professor of National University of Singapore. She is the professor of clinical education in ophthalmology in Duke National University of Singapore Medical School. And she is involved in so many organizations and achieved so many awards like American Academy of Ophthalmology Achievement Award. And she is heading many of the study groups, especially in intraocular inflammation. Dr. Sergio Canabrava, he is the inventor of Canabrava ring. He has developed many techniques, the double flange suture creator. He has developed 4 flange technique, and he is preceptor on Centro Ophthalmológico de Minas Garcias, and he is member of the Brazilian Society of Cataract and Refractive Surgery. And I will be the moderator for today's webinar, and this is going to be live streaming on YouTube and Facebook. So you can join on Zoom or YouTube or Facebook. And there is a question answer box in the below. Please keep your questions keeping on in this box, not in the chat box. If there is any other issues like volume or quality of the video, please put that in the chat box. Other all the questions to the panelists, they are going to be here throughout the full webinar. Put your question and answer session here. So first speaker, I am going to just set the tone for today's webinar, and I'm going to be speaking on the subluxation management, basic modalities and femtolaser in that. The management of subluxation depends on the extent of the subluxation, strength of the intact zonules, and whether there is any vitreous disturbance and grade of lentil opacity. The strategy is to address the vitreous and use appropriate device to stabilize the bag, reposition the bag to its center, and if we can, give in-bag implantation. And these are the commonly used devices that we have: capsular tension ring, capsule tension segment, and Sioni ring. I will be focusing mainly on 2 difficult steps, rhexis and stabilizing the bag. Am I audible?
Yes, we can hear you well. Yeah.
Okay.
But we don't have any picture, any slides.
Can you see now?
No, we don't see the slide. We can see you yourself, but there is no slides on the screen. We can hear you well,
Yeah.
but
Sir,
there is no presentation material.
what about now?
No, not yet.
Not yet, sir.
No.
So till now there was no presentation.
No, there was nothing there.
Oh, sorry.
That's okay. Are you sharing your
Yeah. Okay.
বলতে হবে না
right?
এখন যেন তাড়াতাড়ি আমি এটা
You see now?
আমি এখন দিই
Yes, we can see now very well.
Oh, sorry. So I was not visible. So all the introduction and it was not visible.
That's okay.
Okay, so I would just start from here, I think. Yeah, so start with my presentation. I will not waste the time. So I'm going to be talking on the fundamentals of subluxation management and femtolaser assisted cataract surgery in the subluxation, how it can help. The management will depend on the extent of the subluxation, the strength of the intact zonules, whether there is any vitreous disturbance, and grade of lentil opacity. The strategy is to address the vitreous, use appropriate devices to reposition the bag, and if possible, IOL bag implantation. And these are the commonly used devices that we use: capsular tension ring, capsule tension segment, and Sioni ring. Most two difficult steps are the rexis and stabilizing the bag. The problem with rexis is that there is no support first, and as a result, initiation or propagation of the rexis is very difficult. And we have to use multiple instruments. Like we can start with the cystitome and then grab the rexis with forceps. The other problem is that in a subluxated lens, part of the lens is below the iris. So many a times we can't see when we're doing the rexis, especially where it is under the iris. And sometimes we have to use our intuition to check how it goes. And most of the time it is possible. So this was a very extreme subluxation where the rexis was done without help. But many a times this is not possible. Sometimes in order to complete a rexis, we have to use help of the other instruments. Like in this case, there was a subluxation more than 180 degree, and it was very difficult even to make a puncture in the capsular bag. And after making the puncture with a 26 gauge needle tip, I was trying to propagate the rexis, but as there was no support, I could not go any further. And in this case, I used a Sinski hook to just give a support to the part that I have already done. And these act as a force on the rexis so that we can continue the rexis. And in this case, you can see that I could do it with the help of Sinski. This was another case. The cataract was little in the harder grade than the previous ones, and I started the rexis and tried to continue it with the microforceps, but here I could not do it. So I used the capsule hooks. The benefit of the capsule hooks is that it also goes up to the equator of the lens and supports the bag pretty well. And if we put one or two hooks in the area of the absent zonules, this acts as a support to the subluxated lens, and the rexis can be done. Now, devices, there is a problem that once we have put the devices, sometimes it becomes very difficult to remove, especially the cortical matters, because they are trapped within the lens and the devices that we have. So the timing is of crucial importance. So we should try to put as late as possible, but as early as it is required. I'm going to show two different videos where I could put the device here. In this case, there was subluxation was not that much, and after hydro dissection and delineation, I could take out most of the lens matter. And in this case, I always try to take the cortical matters from the intact zonule area. And because the zonular dehiscence was not much, I could finish the case thoroughly up to irrigation without any device, and then just gave CTR and put the IOL. In this case, the cataract density was little more. So after the rhexis and hydro delineation, I tried to rotate the lens, and I could see that the zonules were very weak on the other side also. So I planned to put a CTR first. And once the CTR was implanted, I could take out the cataract. And this is one trick I want to share, that what I do is I take the cortical matter, and there is a gap between the two eyelets of the CTR. So I would take all the cortical matter up here and then remove it. So once the rhexis is done, how to stabilize the bag for the cataract removal? There are a couple of procedures that we can use. I'll just share a couple of my videos. So after rhexis, we can use Irish hooks to stabilize the bag for the lens matter removal. And we should use more than one or two hooks, because that will distribute the tension. And I have had the experience of that the capsule hook has teared the anterior capsule. So we have to be very careful that we don't pull that bag with the capsular hook too much. So the cataract was taken out. In this video, I'm going to show I have used, after rhexis and putting a capsular tension segment, for stabilizing the bag, I have used a Irish hook. Put the Irish hook in the eyelets of the capsular tension segment, and then remove all the lens matters. And after that was done, I gave a CTR for expansion of the bag. But one thing, the problem with this one is that we have to take that Irish hook out and put again a suture. So we can take that Irish hook out from the side port, and then pass a 9O proline in a straight needle, pass through that eyelet, take it out from the sclera. So we can use two straight needles, take both of them out from the sclera, railroad it on a 26 gauge needle, and then tie it to centralize the bag. And one thing I would suggest, that not to give the final suture here, but centration can be done after the IOL is given, and this can be easily buried just by rotating it in the sclera. And this is a case, what I do now is that give the CTS, capsular tension segment, after tying it to the 90 proline. In that way, I can stabilize the bag, and I don't have to take out anything and just give the lens afterwards. So I have passed the 10-0 proline, and then put the capsular tension segment in the capsular bag, pull this for centration, and then remove the cataract. This is the final video that I'm going to share. This was a traumatic case where we could see that there is vitreous in the anterior chamber. And I had planned a femto laser here. The benefit is that the hard part capsule rhexis can be done with the femto laser. It's most of the time free floating, and we can move it towards the subluxated cataract. See the nice capsular rhexis done, and 6 spikes for disassembling the cataract. So this is how it looks on the table. You can see that there was a free floating rhexis. There was vitreous in the anterior chamber. Whenever there is vitreous in the anterior chamber, we always have to address that. So a triamcinolone assisted vitrectomy was done, and after that hydrodissection and delineation was done. It was a soft lens, so with bimanual irrigation of aspiration, I tried to take out as much as I could. But after removing nearly most of the cortical matter, the capsular bag was coming to the irrigation port. So at that moment, I thought of giving a device to stabilize the bag and complete the case. So here I had chosen to give a Sioni ring with one eyelet, and it's a similar process. I would pass the ninoproline in a straight needle, railroad it through the scleral pocket incision or Hoffman pocket, whatever we can use, dial it in the bag, and then centration of the bag is done by tightening the sutures, the removal of the rest of the cortical matters, and then IOL was implanted. So the take-home message would be that we should try for in-bag implantation. If there is vitreous, we should manage it. Crucially, we have to think of the rhexis, and we should have all the devices ready. So thank you all. So I would now request Professor Tazignan to share her screen and present. Dr. Tazignan, Professor Tazignan, can you unmute, please?
You can see me, yeah? Okay.
Yes.
And then I will share my screen. Hello, everybody. And I will present my approach regarding the subluxated lenses in children. So first of all, do you see the presentation? Everybody sees the presentation?
Yes.
Yeah, okay. Yes. So these are difficult cases. Subluxated pediatric cases are difficult cases. And of course, these are rare diseases, that we have to be sure. But nevertheless, we have in the centers that are doing pediatric cataract, they do have on regular basis children with subluxated lenses. And I tried now for the last years, I tried to have a kind of standardized procedure, because I think that it is always very important to try to get standardized procedures. These were my disclosures. I will not speak too much about it. But what I would like to present is the use of the bag in the lens. I still use the bag in the lens also in cases of subluxated lenses. The bag in the lens is a technique, it's a device that allows you to have a complete PCO-free postoperative follow-up, which is of course a big advantage, and certainly in children, because the children are not that easy to treat with YAG laser capsulotomy. But of course it has much more advantages, and I will not spend too much time on that, because the idea is of course to look at the technique, how we do in order to try to accommodate children with the bag in the lens in subluxated lenses. The bag in the lens is based on the knowledge about the space that is behind the intraocular lens, and this space is called the Berger space. This Berger space is defined by the posterior capsule and the anterior hyaloid, and in the periphery you have, in fact, the ligament of Rieger. Everything was known from 1983-87, but it was never used. It has been used only very recently to accommodate the lens, for example, in lenses where you have the bag in the lens, for example, there you have the optic, part of the optic and part of the haptic that is accommodated in that lens. And of course, when you also use the technique of the optic capture, you of course also push the optic through the posterior capsule, where it will be in contact, or it will be hanging somewhere in the space of Berger. Now the question is, do we also have a space of Berger in children? And then the answer is yes, we do. But the space of Berger in children is often smaller. It's not 8.5 to 9 millimeter like in adults. It is often smaller. It can be 7.5 or even smaller. And what is new is that we defined some abnormalities in that interface, which is called the AVLIT. It's anterior vitrolenticular interface dysgenesis. So we do have some dysgenesis in that phase. And this is very interesting to know what it is about. Now in children with dislocated lenses, very strange enough, they do not have an intact interface. They don't have it. There is a dysgenesis. In fact, the tertiary vitreous didn't do its job as it should be, and they do not have a ligament of Rieger. They just have an interface. They have an anterior hyaloid, not attached at the posterior capsule, and certainly also not attached at the zonules. So there is, at the final stage of the tertiary vitreous development, there was a mistake, an underdevelopment. Now here is the case that I would like to present. And indeed, it was also my intention to try to push back the boundaries and always make it more and more difficult cases. Now, when you look at the dislocated lenses, you always have to look how is that lens located. So here we see that we have nearly no zonules. That means that all the traction is done here at this phase. So it is important to know that. And now I start by putting the marks at the level of the sclera that I will use during my surgery. This one corresponds to the border of where the lens crosses approximately the limbus at this place and at this place. So this is the one that I need to know. Why? Because this is in fact the area where I will systematically put my iris retractors in order to center the lens and to facilitate all the maneuvers. It must be positioned there where it is as symmetrical as possible compared to all the forces of the zonules that are exerting quite a lot of tension here. This one corresponds to the meridian that goes through the middle of the lens. So this is the one that should be here, this space here between that, and the space between that and that should be equal. So that we know that here we will have the place here. Here is in fact the place where the lens will be oriented to. And this one you will see later why I will use this one. Every mark has its use. Now, the first step is to perform an anterior capsulorhexis. And in order to stabilize the anterior chamber, I use a heavy not a dispersus of cohesive viscoelastic. And you see here why I have this one. It's because here I will make 1 millimeter and I will center the lens complex based on these two marks with these iris hooks. Now, heavy viscoelastic device will stabilize your lens much better so that you will have much more ease to make your anterior capsulorhexis. And indeed, as said before, to take away the lens material, this is not a big deal. Now here, look very carefully. I will give you the proof that there is no interface there. When you aspirate, you easily can snap, and here you have it. Here I snap my posterior capsule in my irrigation aspiration probe. And this is the proof that there is no attachment from the posterior, from the vitreous. There is absolutely no attachment. The capsule is free floating there. Only a little bit of zonules are attaching here. And of course, here, quite a lot of zonules are attaching the capsule. But here, behind the lens, there is absolutely no vitreous attachment at all. So in fact, what you also could do, if you want really to be sure, that you are in a safe side, you can inject through these zonules. You could also inject some viscoelastic in order to push back the vitreous as much as possible. Now here, through that little opening, I am inserting the capsule tension ring. And you see that it is a very small bag, but the bag will extend and expand because, of course, this, due to the poor presence of zonules, this capsular bag is retracted and is quite round. Now, with the just inserting of capsule tension ring, this is enough at this stage of the surgery. Now I take away these iris hooks because now I have to adapt the anterior capsular rhexis based on the ring, on the caliper ring that I inserted here, positioned on the anterior capsular rhexis in order to make the anterior capsular rhexis of the right sides. And then I perform the posterior capsule puncture. Don't be afraid, you can inject as much as you want, practically the whole syringe to separate the posterior capsule from the anterior hyaloid or from the vitreous face, let us say that way. And then I can perform my posterior capsular rhexis practically the same size than the anterior capsular rhexis. And then I can implant the bag in the lens, which is not too bad to implant. You will have to exert the most pressure here. And that is the reason why I will do a bimanual maneuver by really stabilizing the lens with one hand and by really gliding with the other hand both capsules within the lens groove. So now we have to face the situation that we have the bag in the lens on its position, in which the capsular bag is inserted. It is quite stable, that capsular bag, thanks to this capsule tension ring. And then I was thinking, let us now put my bean-shaped rings, but do not forget that in most of those subluxated lenses, the zonules are so abnormal, the remaining zonules are so powerful that it is sometimes very, very difficult, even after having inserted these bean-shaped rings, to have a good centration. And I'm inserting 2 rings. I'm calculating the size of these bean-shaped rings by measuring the white to white, and then I add 1 millimeter. So if I have 12, which I will not have in these children, most of the time they have only 11 in the horizontal diameter, then I add 1 millimeter or 2 millimeter, depending on the size, whether it is above 11.5 or not. And this is the situation after having inserted a 12 or 13 millimeter 2 rings of 12 and 13 diameter. And look what we see. In fact, we see that the capsule complex is not centered properly. So I said, okay, I have to use now, because I was practically sure pre-operatively that I will need an additional act to perform. And here you see, I am going to use these 2 marks here that I put on the sclera. And here I have a thread of 6-0 proline. And I'm putting one end of this thread here in this 27 gauge needle that goes through these 2 ones. What is my intention? I now intend to make a loop, put it in the lens groove, and fix it at here, this side, and at that side, symmetrical to this point, which is the meridian of the complex, of the crystalline lens complex, if you remember from the very beginning. So I do it in a very symmetrical way. So this is the first part. I glide it through this 27 gauge needle. Once that I have sufficiently inserted, I take it out, and I put now here the second end of the loop. I glide it here in the next 27 gauge needle, and I glide quite a lot of it. I bring it out, very safe and a long piece of thread, so that I'm absolutely safe. And then I glide this 6-0 thread proline within the lens groove here, in addition to what has ever been inserted up till now. It doesn't matter, there is space enough here. And then what I have to do is just to pull on both of these threads, these ends, and center the complex capsular bag, bean-shaped rings, and this prolane in order to have it very closely adapted there. And then you just have to cut it, and then to heat it, and then you adjust it so that you have a very neat situation of a very beautifully centered lens, capsular bag, intact, and then also the lens complex. You have the lens that is really positioned at the most anatomical place as you can expect within the eye. Most of the people will say, yeah, but this is very difficult. It is not very difficult. I make it very, very a protocol so that step by step, everything can be done. And if you follow this procedure, it's really not a difficult procedure to do. And I think that this mimics very well the anatomy of the eye. I thank you very much for your attention.
Thank you, Professor Tazignan. I think I had the pleasure of attending her OR. I went to her hospital, Antwerp Hospital, nice city and nice hospital, and the operations she does. I think how many times you tell us that, you know, don't worry about doing a posterior capsulorhexis.
Yeah, but you see, that's the problem. Most of the people are afraid about the posterior capsulorhexis because they are not educated in what is behind that. And for me, it is really something that I discovered now. And it is such a pleasure to speak about all the variations of that interface that is up till now unknown. This is the AVD, this is the anterior vitreous detachment, which appears by aging. In every eye, it will appear from age of 50 on, you will have an AVD, just like you have a PVD with time. And that is the anatomy of the vitreous that my big teacher was Jan Worst. And I'm still thinking of him.
We will have a lot of questions, and we will have all the questions after the presentations are all over. So now I invite Sergio. Sergio, can you hear us?
Hello,
Yeah.
I give only on 5 minutes, 1 minute.
So you need to share your screen.
Sorry. Hello?
Yes,
Can I
we
read?
can hear it.
Yeah,
Yeah, we can hear it.
Yes. Yes, now I'm ready. Mary, I like your modification. Good. Nice with the proline. I really like it. Let me share my screen. Okay, can you read me? Is okay?
Yeah.
No, it's
Crumble.
blurred.
What?
It's
blurred.
blurred. It's not.
Yeah. All right now.
It's a little better. Little better.
Okay, let me try. Sorry, I'm outside of my city of Belo Horizonte. I'm in my farmhouse. And if the internet is bad, you tell me, I try to change the place. Okay, today I will talk about the double flange canal technique. Here my disclosure. When did it all begin? It's all beginning in 2016 when I saw the Yaman technique and I saw the flange for the first time. I had the idea to use a simple haptic propylene haptic to create for the first time a double flange technique. And I use it to fixate a CTS in the eye. Then I published it in 2017 and I received a prize in 2017 in Los Angeles. Then I have the idea, why not to use a simple polypropylene suture to create an enlarged adjustable suture. Nobody published it before in the ophthalmology. Is so easy to do, and the price is amazing for a developing country like ours. Then 2018, I published it on ASCIS, patient with Marfan. And then 2019, I published the 4-flange technique here using an aqueous IOL and a 6-0 polypropylene suture that I go through the eyelets of the aqueous IOL and the both parts. And then I back with the third, here the position of the IOL. Here the point, the third point that I put, and I insert the IOL inside the eye with a burrata forceps, 3.5 millimeters incision. And then I back for the 4th point, and then I will do 4 points. In this moment, this kind of fixation is more stable in my research because I do 4-point fixation. I do the down first, and then I adjustable the IOL. And this kind of technique in Brazil, you don't have hydrophobic IOL, but you can do it with physio, and you can do it with artists. And then I think the use of the ProLens, the double flanged suture, can create only in 2019 5 new techniques. And now I can see the new technique of the Marie Jose, and I'm so happy to see how it's possible to use a ProLens suture, a simple ProLens suture, to do a double flanged. And then today I will present the case that I received the Golden Apple in 2019 ASCRS. Let me see. I will present 2 cases. The number 1 is the patient, 2 patients with microspherophakia, and the number 1 teach me about the number 2. I like to ask you if the catalysis report. My question is it the fake news? The position of the crystallines are fake news? In this image, my answer is no, it's real. And these are real catalysis reports, are real. In my experience, in our hospital, you have a catalyst, and it's possible to do this kind of subluxator cataract with catalyst, but with alcohol device is not possible. Look the patient after reflex, the femtosecond. But Sergio, Dr. Canabrava, how did you levitate it? I had the idea because I know microspherophakia horizontal, I insert air bubble behind the nucleus, and I use OVD. Observe how the bubble levitate the crystalline for me, and then I go using 4. Observe the bubble, how the bubble levitated for me. And then I use 4 Macu hooks to hold the bag. But what do you think? Everything was okay? No, observe. I couldn't to fixate this patient, observe the CTR, and what was necessary to do a vitrectomy, and what necessary to do a scleral fixation. But what did I learn from this case in microspherophakia? I was trying to use a CTR with 10 and 12 millimeter. And then I realized, oh man, I need to use a CTR 8 to 10. And in my research, I could find only Madhu instruments from India. And I go for the second case, patient with 7.8 millimeter, as you can see in this case. I repeat my steps, all my patients, I do flex, CTR, and then here the second patient, after the phacomus, the flex, and I use here 4 iris rook to fixate the bag, and then here a visco to create space, and then so slowly the CTR 10.8 millimeters, now the right size of the CTR. It was the problem for my first case. And I like to use a simple Sinski rook. I don't like to use injector. I like to go so slow like in this case. And then I hydroprolapse the nucleus to the anterior chamber, and I do fake emulsification. In this case, I like to perform the fake emulsification in the anterior chamber. I don't like to perform it inside the bag. Here, after to remove the cortex, and then I remove 2 iris rook, one side, another side, and I like to create a space to pass the 26 gauge needle to the anterior chamber. And then in this case, I use a 5-0 polypropylene suture. In 4-flanged scleral fixation, I use 6-0. And double flanged for subluxated cataract, I use 5-0. Okay. And here, I remove the 5-0 polypropylene suture. And then I do the first flange in the first CTS. Observe the CTS, there is an angle. It's avoid tilt. This CTS was developed for Madu instruments. And here again, the other part, the other side, the second CTS, I remove the 5-0 polypropylene suture, and I do the first flanged in the second CTS. I insert it inside the bag, but pay attention, the CTS is too large because this I developed one with Madu. A small one is better for the technique, but it's okay. Then now I do the first flange in one side and the second flange in one side. I cut it about 2 millimeters from the basis, and I do the second flange. Is important. And again, I do the second flange in the other side, and I insert it inside the scleral tunnel. It's important to insert it inside the scleral tunnel to avoid endophthalmitis, to avoid conjunctive erosion. And here, the IOL in the bag. Okay, here, patient with six month UBM. You can see the CTS number 1, the CTS number 2, and here you can send the flange in the sclera. Review of the technique. You need 5-0 Prolene suture, CTR, CTS. I suggest this CTS that I produce with Madu because the angle with 6 degree angle, thermal culture, and the 26 gauge needle. If you use a 6-0, you need to use a 29 gauge needle, but for double flanged, I suggest 5-0. Here, the review of the technique. And my last question, is the double flange technique safe? Till now, I have 21 patients that I did. Alma, Marfa, microspherophakia, IOL subluxation, and I have 36 months follow-up, and the technique seems to be stable. The problems you need to avoid in the learning curve, the size of the flange. If you do a large flange, it can avoid for you, you can insert it inside the scleral fixation, the tunnel. And here my take-home message. Step 1, all my patients with subluxate, I do flex. Then I hold the bag with Maku hooks or with iris hook. CTR, hydroprolapse the nucleus, fake emulsification in the anterior chamber, CTS plus double flanged. Here my Instagram, if you look about more videos, every week I post one video from my hospital that I perform. And it is a pleasure to talk for Bangladesh. It's for my first time here. It's an honor to talk with a great names around the road. And Dr. Mari Jose, you test your modification. I like it. See you. Thanks.
Thank you, Sergio. Excellent demonstration of surgeries. This will give encouragement of the your new doctors to try new things. We'll have a lot of questions. I have a lot of questions I'm going to ask you. Now I want to invite Dr. Vasavada, and he is a teacher to many of us in Bangladesh. I was very lucky. I did my fellowship under him for a year in cataract, and I learned a lot. To share your screen.
Thank you. Thank you. It's always nice to be talking to my many, many friends in Bangladesh. This is my financial disclosure, and I recognize the contribution of my colleague, Dr. Deepa, on this topic. I'm not able to move now. Yeah, okay. I think the ectopia lentis in children, many of the times is idiopathic and sometimes it's familial, but we must look for Marfan's, Will Marchisani, but importantly, homocystinuria, which goes undetected many times. So homocystinuria is something we are discovering more and more because we have started testing for it more and more. Why should we operate? Obviously, to improve the quality of vision, but delaying beyond a limit also would increase the surgical difficulties because the subluxation, the zonulysis will increase, vitreous will degenerate and so on. So I think we should operate for sure. When should we operate? In my opinion, I wait for 3 years of age because any child or eye under 3 years, in my hand, it is more difficult to perform these gymnastics, and also the complications post-operatively are high. So I would like to wait, if I can, until 3 years of age, and I want to see that there is a decreased visual performance over a period of time in first 1 or 2 years before I jump in. But for the parents, and it's more relevant in our part of the world, we must to make them aware of the disease, the potential complications of this condition, and make them aware that quite often it is a systemic condition. This is one part of the disease. There could be heart or cardiovascular or mental retardation and so on, vascular thrombosis. Educated, and they think this is just one of those cataract surgeries. So we want to make them aware. We must evaluate properly, and we must have a checklist of various items we need to do pre-operatively under anesthesia, and also monitor them post-operatively from time to time. Do not give anesthesia in too short a time. Wait for at least 6 weeks to 2 months before you repeat the anesthesia because of the potential neurotoxicity of these gases. But you need to keep in mind, and the aberration profile with subluxated lenses or ectopia lenses, is very bad. They not only have the high order astigmatism, but also the HOA increase. And we evaluated and reported that in the JCRS in 2018 that they had a lot of aberrations and they were corrected after the IOL fixation. So the quality of vision with subluxated ectopias lentis is not very good. So keep that in mind in a preoperative evaluation. But first thing is first, always try to refract if in a subtle, and you help him with the spectacles or contact lens and monitor if you can see that. But generally speaking, it is a surgical option that we will end up on the table, has been emphasized enough in the earlier presentation, extent of the subluxation, and look for presence of the vitreous. So first of all, see how unstable and how extensive the ectopia part is before you finalize your strategy. And we have two challenges: how you remove the lens, and how are you going to fixate the IOL? And we saw a wonderful innovations of Professor Tasigno and Sergio, and there are many others like Yamani and Aglud that you have an option of IOL fixation, but lens removal should be as traumatic as possible. And we have two basic approach: a lensectomy with vitrectomy, or preserving the compartment and a capsular bag. Lensectomy and vitrectomy has an advantage that you can remove completely with no PCOs and no inflammatory material left, ensures a clear visual access, and technically perhaps is consistently possible to perform that. However, there is always a disturbance of antivitreous phase, and Professor Tussing alluded to it so well. Keep that in mind. You are creating an additional factor in the physiology of the vitreous and the trabecular meshwork and so on. So because vitrectomy is mandatory in this condition, you should be prepared for the sequelae. And if you can avoid, there's nothing like it. But there are eyes where most of the surgeons would resort to this condition. And although we saw beautiful videos of such an eye where you can still maintain the bag, and I've done it a few times, but I've given up on that because in my hand, the consistency or reproducibility is something that I don't get with that. So I now, in such a situation, perform a lensectomy, pars plana lensectomy. And remember, whenever we do vitrectomy, along with whatever the procedure in child or in adult, pars plana has an advantage over the limbal vitrectomy for various reasons. So I do what I call the sandwiching technique. I have an infusion, a two-part vitrectomy infusion, pressurizing the globe and the lens, and injecting Helon 5 or Helon GV in front. So in front, the Helon 5 would stabilize, and in the back, infusion. So this lens will stay put. And you will see that the entire lens will be eaten up under the vision. You don't need to chase this lens or dent the sclera to find out the peripheral capsular bag and fornices because of that Helon 5 in front and an infusion in the back. It remains put, and you can do it fairly predictably every time that thing comes. And then you need to make sure that you remove the antivitreous. So having done that, then you have an option of various options. We saw Canberra's beautiful innovation, but I, at the moment, I've done a scleral fixation for many years with Gore-Tex, first 9-oproline and Gore-Tex, and then at the moment I'm doing my way of doing Yamani technique if I have that. But this is a scleral fixation. I just want to caution you against using 10-oproline. They always degrade. I have had many. 9-oproline is okay, but that also can degrade. So I now, for last 4 years or 5, doing a Gore-Tex material, which is used by the cardiothoracic surgeons, and I use 24 gauge sclerotomy needle and 25 gauge forceps. I stopped doing railroad because the needle in the Gore-Tex is terrible. It's very difficult to do railroad with this. So with this 25 gauge forceps, I'm able to handle it in a very controlled manner, these ropey, thick material, Gore-Tex. But at the end, it's very good. So I do that as a routine now if I have a lensectomy or a no capsular support, the scleral fixation. Recently, for last year and a half, I'm doing Yamani, and I recommend that. But whatever you're using, make sure the key is the vitrectomy. You do with a pars plana, and that will reduce the acute vitreous interface fraction and the late sequelae of that condition. So that's how it would look under the thing. But the more interest is to preserve the bag and then reposition it. And the advantage of that is really, at the moment, is that you can preserve the antivitreous phase and you don't need to do vitrectomy. In the initial stage of learning, you may disturb the vitreous, but as a rule, 9 out of 10 times, you will not need to do vitrectomy. And that's the reason I really like this concept, in addition to all the other known things. It is rather technically demanding. It has a learning curve. And if you use 9-oproline, or others, you have a problem. But if you use proline, maybe 6 is okay, but Gore-Tex is for sure is the right way to do. The first thing is to understand that we need to have a closed chamber technique, no hypotony anytime in the eye. It's lethal to the back of the eye, interface, vitreous retina, tamponading the vitreous phase, barrier effect, capsular back stabilization we saw, and slow motion technique. So first thing is, if you're not sure, always make a 1 millimeter incision and inject Triumph Cinnalon preservative-free. I use Indian-made Orocort from Orolab, and make sure there is no vitreous. If it is, you need to do vitrectomy first before you proceed, or if you've already done flex, that's okay. Now, tamponading using soft shell technique of Dr. Arshinov, a barrier effect of dispersive, using viscose on the open area, and then using Helon 5 or Helon GV in the area of your rexus. And that also will push that viscose right on the top of the open face so that vitreous face is protected. And that was well commented and taught in the earlier presentation. So that's the tamponading the vitreous face and making sure that your environment is good. And once again, you see that viscose going in and then having the heavy cohesive viscoelastic there. Simple Helon or a Provis doesn't work, or it's not the best heavy adaptive viscoelastic. So I prefer that. And then there are various ways of doing the rexes, and you will see more from Sunfaik later on how you stabilize the rexes. And you saw Istiak showing with the Sinsky hook, whatever, try to do the rexes. I try to do it under vision because my proprioception under the iris, blind procedure, sometimes can extend periphery. So I try to do 2-stage rexes, a small rexes, and I don't need too big at the moment. And then I will enlarge it later on once I'm ready to do that. So having done that, the next stage would be to stabilize the bag. And I use iris hooks, capsular bag, capsule supporting hooks. I don't use very much because they need larger incisions. And these small bags are shrunken bags, and these Greischeber iris hooks does the trick. But what I do and what my colleagues showed some time ago in an award-winning video is that viscose dissection following fluid dissection does create a good space. So we do hydro dissection first, and then injecting dispersive viscoelastic to maintain the bag. And if you're not put the CTR, you don't need that because that viscose will take care of the inflation of the bag. And then you can repeat that viscose during the procedure. Notice my flow rate is only 5 cc per minute. My flow rate now is only 5 cc per minute, but by vacuum is 300, 400. So low flow rate and irrigation port in the bag, irrigation in the bag, fluid inflating the bag all the time, and viscose already there, you can re-inject. We'll make sure that the bag posterior capsule doesn't cut, that floppy capsule, and Marie-José alluded to the lack of support from the dysgenetic vitreous. But whatever that is, you can now enlarge the rexes to make the implantation of the IOL in the bag less traumatic and stressful, and also to prevent the capsular fibrosis later on. You can use the Greischeber scissors to cut that, but that's your judgment. Then once again, like Sergio said, I use a small size double hook. This is made from Orolab, and this is as small as Sergio said. The overall diameter goes up to 8 millimeter. So these are shrunken bags. So I use this Indian-made Orolab company, small Sioni ring. Typically, I use 2-point fixation, either with CTR and segmental ring, but generally I prefer 2-ended Sioni ring, but a smaller ring, not the conventional ring which the moisture size has. So this is little fiddly because there are already thick ropes of the Gore-Tex, and there are 4 ropes. So you need to be a little careful, but it's not that difficult. It's not that difficult. And you position that and align that, as was shown earlier, into the apex of the highest subluxation, and then introduce through the limbal incision one end of that Gore-Tex, and then 24 gauge needle, just enough to enter, not into the antivitreous phase, just enough to enter through the sclera and choroid, and then use 25 gauge forceps to take that out. And then you can do that again in the second one like that, and same thing on the other side. So this Gore-Tex suture, C-only ring, 2-point fixation really stabilizes very much, and at the end it looks fairly stable, and the Gore-Tex is not degradable. But implantation, single piece Acrysoft or single piece hydrophobic or whatever your choice, will go very easily with this 2-point fixation. But at the end, we need to make sure that you position in the right direction, and check at the end with triamcinolone in case the vitreous has come, and if it is not, you can do it with irrigation aspiration as you could find. Now, long-term suture degradation, I saw 9-0 and 10-0 Prolene being used earlier, and I've used it for years. But now I would recommend you to consider either 5-0 or 6-0 Prolene. But my preference today is Gore-Tex, either this technique. If I'm going to flange it, and I do sometimes in some situations, I use 5-0 Prolene. We reported in Indian Journal very recently these Gore-Tex of 100 eyes in the long-term follow-up, and they all remain very well. Dr. Asia's anchor device is one of the segmental stuff, which is very good, and that also can be used like stabilizing the bag during the surgery, or later on, as you saw in the first presentation, ultimate bag. You can go through the hole or through the neck of the thing, and you can do exactly like the segmental ring, and you can then reposition the bag as you can see. And similarly, iCamera segmental ring, but I use Gore-Tex here once again, and not the Prolene because of the long-term degradation. And this is one more example to say that what was Istiak showed it beautifully, how difficult it could be to puncture. But then if you aim a small rexus and try to push that towards the intact zonules to initiate the puncture, you may, but you may have to support that with the other hand forceps, and probably I'm sure Sunfek will show you that very elegant way. But you can stabilize the capsule if you have a struggle. But if you are lucky to initiate the puncture, then you can hook it up with the hooks here or forceps and do a small rexus, and then later on enlarge it to the second rexus. This is a single point fixation and not 2-point fixation. And same principles, go very slowly, and then introduce one end of the Gore-Tex and pass the 24 gauge needle, and then 25 gauge forceps, curved forceps. I have modified the Aikida forceps by Indo-German company from India, but there are many such elegant curved forceps. The straight forceps don't work very well. So you need a curved forceps to suit your ergonomics. Second end goes, and the 25 gauge will grasp that, and then it's very easy and titrate your tension. With Gore-Tex, you don't need 3-1-1. You can do 1-1 or 2-1 or whatever. In other words, you don't do too much, and then you can always enlarge this rexus later on. It's very easy to enlarge the rexus there. I'm not sure what happened here, but
Hello. Yeah. I think your video is stuck. Professor Vada, can you hear us? I think he's having some internet problem. Dr. Vasavada, can you hear us?
Maybe show him something that you write down that he can read. He most probably can read, but and
yeah.
if you can write something that he has to close everything.
Yeah, he has to close everything, otherwise we can't continue. Vasavada, can you hear us? I think I will write it here. I think he has lost his communication. Okay, Professor Chi Sunfei, can you hear us?
Yes, I can hear you.
Yeah. Okay. I would like to invite Professor Chi, and I think wherever we go for the conferences, we are always looking forward to learn new things from Professor Chi. So I would invite her to start the presentation.
So thank you very much, Dr. Anwar, for inviting me to join all these great giants, and I've been really enjoying the talks. So I decided to speak on management of severely subluxated cataracts, and I think this really goes very well with all the preceding talks. My financial disclosures with no relevance. So, very often I show my technique using the Godex suture, and I think it's a bit bewildering for the observer, especially someone who's never seen this before. So I thought I'll present it this way. Now, if you have a Sioni 1L ring, like, what we've seen Dr. Vasavada show with a Godex suture that's preloaded. Now, if you want to get to the scleral fixation point, all right, about 1.75 mm posterior to the limbus, how would we be able to bring this suture to that point from the main incision? So if I showed you a lasso, all right, which is formed by a loop of another suture, you'd say, well, that's easy because all you have to do is to pull the lasso and you'll get this suture to where you want it. So I just now show you the eye, all right, and now you get the idea that this goes through the scleral fixation point here, right, just behind the limbus, and this is pulled out as a loop, and you put the end of the suture that is loaded onto the capsule tension ring through it, and you pull it, and then you'll get this suture out here. Okay, so I'm going to show you some videos, and of course, if you're uncertain, you can always look up this paper here. It's being published. So this is a severely subluxated lens, all right? I think Dr. Vasavada would have said, well, I think you should just do a vitrectomy. But I did a vitrectomy, but decided to save the lens, all right? So this is how I bring it forward. We've seen Sergio with his innovation and using gas, but I just use a 27 gauge needle, and this has been published more than, I think, about 15 years ago. And you use hooks to support, all right, as you go along to provide the counterforce when it's not adequate. You can then use a second forceps, all right? This is non-tool, so you don't tear the capsule. And then you can go around. And what do you look for? Your guidance to get it round and right size, you look at the equator. This is creating the suture snare. I showed you the lasso with a 26 gauge needle. You can use a 27 gauge needle, which is what I do now, all right? So we have that already pre-threaded onto the Sioni 1L. And you can just gently insert it into the capsular bag after creating space under the anterior capsule with some viscoat, all right? And then hydro dissection, I like to do things in the bag. So I actually have got the equator expanded. So the equator is held up against the iris so that no fluid goes behind and no vitreous comes forwards. And with a non-rotational technique for removing the cataract, you can see here, we have got this epinucleus here that actually keeps the bag away until the very end. And because we've put the CTR on the right plane, we don't trap the cortex. And this patient had requested for some kind of ability to read his computer after his surgery. So I put in an EDOF IOL here. and marking 1.75 mm behind, doing a Hoffman pocket. You can go through with this suture snare. I extend the loop, right, the lasso, and then we put the end of the suture through it, and we retrieve it at the scleral fixation point. All right, this is going through the full thickness of the Hoffman pocket. Now you can just extend it from any direction that's convenient, and then you thread it through and you pull it out. All right, so once you have this, I want to make sure I have no vitreous left that's in the anterior chamber or where my sutures are passing. I then stain the vitreous again with triamcinolone, and then when I'm sure it's clear of vitreous, you retrieve the sutures using a Sinskey hook from the Hoffman pocket. And I've just rotated because I just wanted to have a look at the IOL to ensure it's well centered. Now, because it's a Hoffman pocket, the suture sits back, the knot sits 1.75 mm behind. And that's why you tie it and then you let the knot drop back to know your final position. I'm going to show you another patient. So this patient actually has traumatic mydriasis following a shuttlecock injury. And this lens is sitting on the anterior vitreous. He's in his 50s, and you can see just the edge of that vitreous coming around the equator of this lens. And this is actually a free floating lens on the anterior vitreous. So again, you can see as I'm pulling, this lens wants to just rotate along. So you have to provide the counter force. And in this case, well, it's in the iris, in the anatomical position, in the correct plane. So, okay, I can just use two instruments without any hooks to support it, because in the other case, I needed the hooks to support it in the anterior posterior direction. Here it's in the correct plane, so I can just use my forceps. And then I take out the capsule bag hooks, right? They support at the equator, but this is not enough, because if I just do that, I don't have anything expanding the equator, then the bag can come forwards in between. So it's very, very important that you put in a ring to expand the equator so that you don't catch the capsule as you do the surgery. So in this case, this is a 1-point fixation, the Sioni, and then that's the time I do hydrodissection. You look at the technique, it's the same. So you will see that, consistently, we're all talking about having consistent techniques so that we don't have to worry about the case. Every case that we do is going to be reproducible and the outcomes are reproducible. And you'll see in this case, again, the technique is very reproducible. All right, so in this case, you'll see that really there is no cortex that I have to struggle with. And I felt uncomfortable with the vitreous coming around the edge there. So I decided to just make sure that there's nothing coming forward. So I'm behind the bag, right, with triamcinolone. There's nothing coming forward. I put in my IOL. And then at this point in time, I'm going to create the other fixation points. Okay. The only disadvantage of having a Sioni 1L is that if you try to rotate this in a bag with no support, you would have great difficulty. So you really have to put your fixation point exactly at where this rig has landed up. All right. So the opposite point is going to be the point that I would choose for the capsular tension segment to provide 180-degree total support. So this is preloading a capsular tension segment, and it's easy to use the segment because there is no top on the back when you insert it into the capsular bag. It just sits exactly where you want it, all right? But the problem with the segment is that actually it's anterior to the bag complex. So there is a bit of rotation, a bit of torque. It would be better if it's in the same plane, right? So again, you look at the IOL for centration when you do your tensions to get this into the right position. Now, what I want to share with you, in fact, in this video and the next, is the importance of getting the iris right. All right, you can do a great job, get your lens centered, well supported, stable, but the patient will not be so thankful as if you had done a repair of his large pupil because of the glare, the difficulty in reading, and so on. All right, so this is a very important step, and it doesn't take a couple of minutes. And this is thanks to Amar Agarwal, who's made this so simple. 4th row. Okay, so you just throw it around 4 times and you pull, all right? And it's a single pass, and you can do it for the other 2 points because you don't want glare coming through these holes if they're left unclosed, right? So at the end of this, the patient was really very grateful because this eye, being a light iris, it can be seen by any person looking at him. Unlike for Asians where we have a dark iris, so he actually had a very well-matched pupil size. Now this is the final case I'm going to show you. This is more difficult, a lady again with a shuttlecock injury. And you can see that there's vitreous in the anterior chamber. I decided not to stain it because it's already stained by pigment and the background is white. So it doesn't make sense to put in the triamcinolone. I've already got pigment, I've got blood there staining it. You can see the blood streak from the trauma. We had to wait for this to be to clear before we could do the case. And you know, this is intermittent, all right? But because the zonules are not pulling on the anterior capsule, you don't get the Argentinian flag sign. Sorry, Sergio, you won't see it. Nowhere near South America. And then, you know, once you have a good size rexis, you just apply your support next to the equator, right? So you'll see that very often the steps are very similar, all right? Because of the concepts of expanding the equator. But in this case, you know, she has no iris here, all right? Because of the trauma. And that was why when I did the vitrectomy, I did it from the front because I actually went through the little gap there to do the vitrectomy. You will see the vision blue has actually gone right through the absence of zonules here to stain my vitreous to make life really difficult for me. And I had a blue reflex rather than a red reflex to guide my surgery. So in this case here, we're going to fixate. And this is again using a Hoffman pocket, Gore-Tex suture, as Abe explained, the needle is horrible to use. And that's why I prefer to use the suture technique. You don't need to buy extra instruments, right? You can just use your needle. And as I said today, I use a 27 gauge needle, and this 7O Gore-Tex, which is called CV8, goes through beautifully without difficulty. All right, so once you have got the capsule tangent segment put in there and your support inserted on both sides, because this was really a very loose lens, and this is a 26-year-old young lady, I decided I needed to support both ends because she has many years ahead of her. So again, you can see the blue reflex, right? Sometimes even though I had stained the anterior capsule under viscoelastic, it still escaped to the posterior segment, right? So this is showing the lasso. Bring the sutures to the scleral fixation point, retrieving the sutures, and again checking for vitreous in this case, and you can see there's no iris there. So I've actually gone beyond the equator of the back to exactly where the base, vitreous base is, to trim that vitreous again, all right? So I put in viscoelastic, and I'm now looking at the IOL for centration. Now, as I said, you know, there is no iris here. All right, there's no way I can suture it like in the previous case of trauma. So what am I going to do? Right, so in this patient, I did discuss with her the possibility of using artificial iris, which I've refined to 9.5 mm because she's not a high myope. That's usually about the bag size. It would fit comfortably. And then I put it into an injector and I'm introducing it into this capsular bag. It's important. If you did it for normal eyes anyway, not a white cataract, you would want to stain the bag so that when the iris goes in, you can see and ensure that this artificial iris is inside the capsular bag. Okay, and at the end of this, you take out all the viscoelastic, and then this is the patient, and she had a normal looking eye. So these are the pearls for very severely subluxated cataracts, all right? You want to use IV mannitol if the anterior chamber is very shallow. Avoid it if it's actually dropping to the back of the eye. You deal with all vitreous when it's presenting, especially in the anterior chamber. Before you start, you need to clear it. Try bimanual CCC for these eyes because really there's no counterforce for you being able to comfortably or easily tear. And inject viscoelastic, very important point, just below the anterior capsule and insert the CTR into the space and do it early because there are no zonules to support the equator and you don't want to catch it and rupture the capsule and destroy your surgery. Now, of course, like in the last case, I had done a femtosecond laser and the femtosecond laser is able to cut through even the vitreous in the anterior chamber, and that really is a great help in these cases. Oh, sorry, the last case didn't have, I changed my video. Yeah, so if you had femtosecond laser like what other speakers have shown you, it will be really a great help because it cuts down the surgical time and allows you to actually center it on the scanned capsular bag if you're using the catalyst. So these are some of the tools, and this is the suture technique which I talked about. Thank you very much.
Thank you very much, Professor Chi Soon Fate. Can you please stop sharing your screen, Professor Chi?
Yes.
Yeah, thank you. I think Dr. Vasavada has again joined us. Yes, now I would like to invite our panelists, Professor Jalal Ahmed, Professor Prakash Kumar Chaudhary, and Dr. Mahbub Rahman Chaudhary.
Ishtiaq,
Yes, please.
I finished my 2-3 slides presentation.
Yes,
I did
certainly,
something got wrong.
sir. Please share your screen.
So I can't do that at the moment. I don't know what has happened again.
Can you start sharing your screen, sir?
Yeah, I'm doing that actually. I'm not able to do that.
Sir, you have to click on the PowerPoint first.
Is that right?
Yeah, you have to click on the PowerPoint first, then.
Right, okay.
Yeah.
So I think we saw that you need to do one two-stage operation, and then at the end, always check for the presence of Triumph's vitreous in the chamber, always, whenever there is a PCR. So finally, what has changed in the management of ectopia and sublens? We saw a beautiful surgical innovation and the control, but the key is the consistency. Whatever the technique you have, make sure you are able to reproduce the technique in your hand. And then the sutures, which remain forever or for a long, long time, 5O and 6O and Gore-Tex in particular, really have changed the way we are managing. So that's the only thing I wanted to share with you at the end. So thank you so much for your patience. Thank you.
Thank you, Dr. Vasavada. Now, I would invite Dr. Mahbub Rahman Chaudhary. Can you please unmute the panelist? Yeah. Professor Jalal Ahmed, please unmute your. Dr. Prakash Kumar Chaudhary. Yes. Dr. Mahbub Rahman Chaudhary.
Yes.
Hear?
Yes.
Yes, we can hear. And thank you, all the presenter. And we have been listening to the master, and it is always pleasure and honor to listen to such presentation where we saw the master showing us the technique, and we are so engrossed in this presentation that nearly 2 hours has passed, but we have hardly realized that. And it is always pleasure and honor to be present where Dr. Vasavada is there. He's my guru, he's my teacher. And Dr. Chi Soon, is always pleasure listening to her. And also we had Dr. Sergio, Dr. Tassignon, and it is a wonderful presentation. And just a few comment here is that to the presenter, that how do you do the biometry in these cases? For the beginners, if you have some suggestion, that would be definitely very helpful for all of us. And at the same time, to Dr. Vasavada sir, you have been saying that lensectomy is a better option than placing the lens, than keeping the capsule intact and putting the lens in the bag. What is the long-term benefit of lensectomy over the in the bag implantation and preserving the lens? May I have?
Yes, please. So I think I just want to clarify that my preference is always repositioning the bag.
Right.
But the eyes, which Marie-Jose and everybody else showed, the total loss and the spirophakias and things, I would suggest in general to perform lensectomy. I've given up on these procedures because quite often I end up eventually disturbing the vitreous or performing a vitrectomy. So if I know in my heart that I will need a vitrectomy in this case, I will straightforward do a pars plana 2 or 3-port vitrectomy, lensectomy, and then do that. But otherwise, all subluxated cases, my preference is always Sioni ring, and I believe 2-point fixation of these bags is really desirable than a 1-point fixation.
Thank you, sir. Thank you.
But even if the lens zonules are intact in one place, you would put a C on it, two eyelets, and
Yes, yes,
stabilize.
because eventually you're pulling. Remember, the zonules opposite to that. If it is more than 50%, for example, and if you pull it, the other zonules are stretched, and eventually they can decenter. So I have done 1 point only, but now I realize on the long-term follow-up, many of these patients with 1 point fixation, they do decenter. So 2 point fixation is always desirable, unless the subluxation is 3 clock hours or 4 clock hours. Anything more than that, I now prefer 2 point fixation.
If I can make a remark, we didn't speak about the artisan lens, and there is a comment here in the chat. Why not the artisan lens? It is still very valid technique. There is now just a paper that is in review. It's not ready yet, but it had very beautiful reviews showing that in fact the artisan outcome in the refraction is even better than with the Yamani technique. I think this is not, I'm not surprised, because I think that it is often a little bit tricky to put the lens on the right size. And to answer the question of Dr. Maboubour, is that regarding the how do you calculate a lens? It is a very important question, certainly when you are dealing with children. Normally, what you are sure about of your measures is the corneal curvature, of course, that you are absolutely sure about it, and you are also sure about your axial length. But the children will, their eyes will grow. So this is depending on the age. Luckily, children with dislocated lenses, they are a little bit older, and their eye is already in their final stage of maturation. They will not have a very curved cornea. They will not have a very long eye. But anyway, you do not know. It is always a little bit tricky. So I think that that's the reason why it is much better to have a monofocal lens than to have complex optic lens, first of all. And second, that's the reason why it is very important where you make your stitches at the limbus, so that you have approximately, it's a learning curve. Nobody has any, there are any data that are present nowadays in order to calculate that correctly. And this is the reason why in Europe we are starting now the Eureka project. The Eureka project is a European registry on childhood cataract. And we would like to gather as much as possible data from children, not only the data of the children, not only their age, etc., but all the different types of cataract. Just like I started, cataract in pediatric is still a rare disease. And all the cases that you have seen are in fact belong to rare diseases. So if you want to make conclusions, you need absolutely to have big data. And to increase your data, you have to work multicentric. And this is an initiative that is taken by the ESCRS. We are practically ready to go and ready to start. It will, the prototype of the database will start, and this year even COVID will not have influenced the rhythm of our work. But anyway, I think we cannot answer yet all the questions, and we hope that with increased data that we most probably will be able to answer your question. And this is, I think, the reason that once that you start a technique, it is much better to try to stick to that technique if it gives good results, of course, because what you have to do is to make it really to standardize protocol. Otherwise, you are just changing all the parameters again and again, and then you have to start all over again, or your calculations regarding the outcome. So it is a very tricky question, and and it is not a straight answer that we can give you on that, I'm afraid.
Thank you, Dr. Tassignon, for your wonderful answer. Now over to Professor Jalal.
Yes. Thank you.
This thing, Professor Tassignon, you are talking about the iris claw lens.
The iris claw lens is for me still an option. You know, if I have an iris, it is still very predictable where the lens will be positioned in the anterior chamber, unless you have, of course, an eye with also anterior chamber anomalies. And this is something that you always have to look at. And I'm a little bit against those standard approaches by just you have your calculation formula, you put your data, you put them in, etc. You have to think about what you are dealing with and looking really very clearly and carefully whether the eyes, the parameters of the eye, belong to the norm, whether they are not outliers. Because once that you are dealing with outliers, no formula will help you really. And that is something, of course, approximately, but this is something that you have to say to your patients beforehand. And that is the reason why I like to have a lens that you can explant very easily. For example, the back in the lens to explant, and it takes you just 10 minutes and that's it. And I think that we have to think more and more about it, what we are really doing. Okay, that's a whole discussion and that's a topic as such.
Thank you. So I would like to invite Professor Jalal Ahmed for any comment. Just before that, I want to ask Professor Chi Soon Pek that she is dealing with all the inflammation. And there was a question from one of the audience that, why you would go for all these things and rather put a easier Irish claw lens. So what is your take on the Irish claw lens?
I do use the Irish claw lens, but it's a 5.4 mm incision. Even if I put in the artificial iris, I would rather put the human optics version than a big mortar lens, which has got a 10 mm incision. So it's all about saving the incision so that the patient has a quick recovery. So, if I had to explant an anterior chamber lens, not infrequently, I will put in an iris claw lens, flip it on the other way around, and retropupillary fixate it. So I do use it, okay, but in most of the cases, I would still prefer to have the lens in the bag. And, I don't think I will face vitreous problems and retina problems if that lens is properly secured, because, it's with the CTR in the bag, it expands that capsular bag so that it actually keeps the vitreous away. And I think these patients have lower risk of glaucoma as well.
Thank you. Professor Jalal. Yeah, sorry, Dr. Vasavada.
Yeah, I just want to comment on the iris claw lens, which is a very good idea, and I endorse it. But in children who has to have many, many years, this lens, which is little wobbly, which is donatic, I've seen quite a few patients, not necessarily because of that movement, but I believe that has contributed, is on the macular changes, the vitreous, retina, and also the endothelium. So iris claw lens has this question mark, which a long-term follow-up has to be done in children because of this very nature of that fixation.
Okay, Professor Jalal Ahmed.
Yes, it was a great, it was a good pleasure and for me to enjoy the challenging surgery by the great surgeons and our great teachers. And we see a galaxy of surgeons presenting so much beautifully the excellent surgery, the difficult surgery. They make it so simple that it was actually sometimes it was a dream, and then make the dream a reality. And also there are some questions for our great teachers. One question to the young surgeon, Dr. Sergio, that you have shown that 4 planes. If somebody wants to use 2 planes lens, like the single piece lens, is it possible to do that? Dr. Sergio, please.
He's not at the meeting. He left the meeting.
Oh. No, he's here.
No, I'm here.
He's with us.
Oh, you are here? Okay. Okay, good to see, because I wanted to send her a message and I received he left the meeting.
No, I'm here.
Okay, very good.
My internet is bad, but I'm here. Single piece.
Use 4 planes lens, 2 planes actually the hydrophobic IOL with 2 haptic, whether it can be done.
Yes, in Brazil, we don't have hydrophobic IOL.
for eyelets, like Acro, Artis from Crystal Lens. I'd suggest if you have hydrophobic IOL with four eyelets, you have 4-point fixation on the sclera. It's
Yes.
more stable than 2 points. Like Lewis and Malbran technique, you need to insert the IOL in the circles to avoid tilt, but it's 4 points.
Yes. Thank you. One question to Professor Mare Jose, that your lens is a special type of lens. It is not the commonly used lens, and you are always using that type of lens. Your result, you are claiming that good, but is there any more and more surgeons are using in your place this type of lens?
Yeah.
It seems to me that it is very difficult. I'm afraid of doing like that.
Yeah, this is of course always the same remark that I receive. It looks difficult because it is not used by or not learned by so many people, but it is very simple. I start my trainees to start with that technique. And I think that the big advantage of this lens is that you really do never need anymore a YAG laser capsulotomy. It's not necessary anymore. But it's not only that the advantage, because it is a lens that is very well accepted within the body with very, very, very few reaction in the eye. It is really very biocompatible, and the healing process of the remaining capsular bag is very symmetrical over the 360 degrees. So the position of the lens will always be very stable in the eye. You will never have, due to the healing process, you will never have changes in position of the lens, except of course if you have problems of the zonules. And yes, luckily we do have more and more people to implant it. In Europe, it starts to become really very popular. Morsha had to adapt his manufacturing process because they couldn't follow. So now I think that it is a lens that is considered to be really a lens that stands next to the traditional lenses. Of course, quite a lot of people like to keep the YAG laser capsulotomy because it is a big income for the most of the referral doctors, and that's still the reality. Let us say that the lens is most used for the people who do pediatric cataract, who do vitreoretinal combination or cataract and combined vitreoretinal surgery, and then of course those who are interested to use the bag in the lens. We are now, it is also used now more and more in other countries, and yeah, I must say, I'm doing now quite a lot of surgery in Africa, and I'm absolutely sure, and I'm making now a business plan to have the lens introduced in Central Africa, in Black Africa, because those people, they do not have any YAG laser capsulotomy anyway. So operating those children is practically doing nothing. It's remote, is replacing the problem for a couple of years later. So we are doing now quite a lot of work for that. And no, I think that, yeah, I had a collaboration with Physio to make it, to use their trifocal and EDOF lenses, but they are afraid that their normal line of lens will lose of interest, so they are not. They stopped the collaboration with us, and I must say, but that doesn't matter. There are other ideas, and there is also an Israeli company who has a new idea about, very beautiful idea, I must say, regarding an accommodative bag in the lens. So looking forward, it is. I think that in such case, you have to be. You know, it's only very new that based on this lens, we discovered the space behind the lens, and we understand much better what is happening there. And I think that the novelty is quite important, so that it needs time before people are accepting it. For most of our colleagues, the space behind the lens is a black box. They do not know what it is, what the anterior interface is. And also for me, I discover every time new things, new anomalies, and this is just, yeah, this is the reason why it is lovely to continue to work with that lens.
Okay, thank you. Another to Dr. Bhasabada, he is also my teacher. We want to know that if one wants to face the ectopia lenses in children, then during his planning, whether he has to change the plan according to etiology of the ectopia, say for example, Marfan's, homocystinuria, traumatic, maybe ectopia with glaucoma, ectopia with retinal complication, or ectopia with aniridia, is whether the surgeon has to make a separate plan during starting surgery. Sir,
I think, I think it is very important. Quite often they have this posterior segment anomaly or a glaucoma in Marfan's and homocystinuria. So I think we need to be careful about it. But the basic paradigms of removing the lens remains the same. Then you need to decide the IOL fixation. And if you can preserve the bag, all these techniques of bag repositioning remain still the same. You may need to do additional procedures like valve surgery or a pupilloplasty or whatever, but the basic remains still the same.
Thank you, sir. And after surgery, whether amblyopia treatment is to be given to these children?
I think there are two issues. One is that we need to do YAG laser these children. Many times these in the bag sublux lenses would opacify, and you can easily laser them once they are able to sit in front of the machine. Generally about 6-7 years age of child will be able to do that. But that's one procedure we need to do. And obviously we need to take care of the occlusion therapy, continuous monitoring of the refraction, axial length, and so on, like any other pediatric cataract.
Yes, sir. For preventing PCO, what is to be done during surgery? Is there any planning?
Generally, YAG laser, but I had 4 or 5 patients where I had to do actually a pars plana capsulectomy and vitrectomy later on, because those children were mentally not able to sit there in front of the machine. So, but you need to perform that YAG capsulotomy.
After giving CPR, for doing posterior continuous capsulotomy, is there any difference in strategy after giving CPR for doing a posterior capsulotomy?
I think posterior capsulorhexis, I believe, will become a routine even in this repositioning of the bag and you know, with the rings. At the moment, we are doing it only in a very small segment of our children who are very small, 3 to 4 years. I sometimes do PCCC also to prevent the post-operative YAG capsulotomy or capsulectomy. But it's not any difficult. Once you put a ring, the capsule will become flat. And if you do not over-inject that PCC like you would have done in any other eye. And Mari is the one who has really taught all of these how to perform PCC.
Yes. Thank you, sir. To Professor C. Sun Phaik, that for doing a femtosecond laser in subluxated cataract, is there any limitation of subluxation, that how far we can go, plan for a flux femtosecond laser capsulotomy?
So it really depends on the position of the lens. If it's really too deep, right? And we have seen some amazing cases done tonight, you know, where it was really very deep in the case of microspheral phakia. But sometimes I've tried, and depending on which particular platform you're using. So if it's too deep, usually it may not be able to reach, or it's very tilted, it cannot actually image. But if it's very anterior, usually I don't really have a problem using femto. And in those cases, it's really very valuable, because doing a CCC with the lens pushed very anteriorly can be very, very difficult when there's no space.
Thank you. And last one question to Dr. Sergio, that for our young surgeons, it seems that you are doing surgery so easily. What should be your suggestion to our young surgeons so that they can learn your surgery? What will be your suggestion? Dr. Sergio, please.
Sergio, can you hear us?
Sorry, can you repeat, please? Yes, I can hear you now.
Yes.
Can you
What
repeat
is
the
your
question?
suggestion to the young surgeons to learn your procedures? Can you hear me? Can you hear me?
Sergio, are you with us? I think he's in the farmhouse and he has got
Yes, the internet
Okay.
is unstable.
I invite Professor Prakash.
Professor Prakash, can you please unmute and have a comment, please? Professor Prakash Chaudhary. Unmute, please. Unmute, please, Professor Prakash.
Now, am I audible?
Yeah, please.
Okay. Thank you, Dr. Istiak, for your hard efforts for this great webinar. And also thanks to our chairman, Maharwan Chaudhary, for giving me the opportunity to share this platform. This is the first time in with my mentor, Basavada sir. He is a teacher of many of us and is a pioneer ophthalmologist all over the world. And I always feel proud having sir as a mentor in my life. We have seen some amazing presentations from world-renowned ophthalmologists. So I have a comment on the Professor She has shown that extending of the anterior capsules technique. We reported one case when I was in Rogudev Eye Hospital. There is a liquid trypan blue percolated into the vitreous through the weak zonules and extend the vitreous under air bubble technique. And it was recommended at that time that we use extend the anterior capsules trypan blue mixed with the hyaluron 1:1 ratio, and it was effective. So to not to percolate into the vitreous. So I would like to know opinion about this. And second question to you, even you have shown that you extend the under cohesive OVD, even then they extend the vitreous. So second question is, what is your opinion regarding the implantation of premium IOL? You implant the EDOF, but what about trifocal IOL or the toric IOL?
Okay, so your first question, in this case, the trypan blue, as you noted, was actually stained under viscoelastic, and I thought I was able to control it. But be mindful that in this case, the patient is deficient in the iris. So it's really very difficult, to prevent any kind of seepage because there's no iris there to halt the tracking of the dye towards the posterior segment, even though I was very careful and I tried to limit the staining to the center where I was going to do my rexis. So, I mean, this has happened to me, in the past when I didn't realize that the patient had zonulitis. So I just did a case this week. It was a young man with an intermittent lens, and he had a capsule fibrosis. And I stained his anterior capsule, and I did the surgery. At the end, I told my fellow, look at the vitreous. You can see actually that one portion is actually blue, and he must have an area of zonular weakness there. And because of that, I inserted a capsule tension ring. So sometimes we don't even know where the zonulitis may be. And I remember another case where I was trying to protect, the dye from going down in a certain direction because I thought area of the zonules in that area was weak. And it actually went through the other zonules in the opposite direction. So it can be sometimes a bit challenging to control the way in which this dye moves. And as you said, mixing it with trypan blue could be a good technique, but I've not tried that. So the second question was regarding the type of IOL. I wouldn't try putting in a multifocal like a trifocal because I think that the biometry has to be accurate, and the ELP is really quite difficult to predict in these eyes. I do fudge a little, say for example, if we do the biometry and the lens is a bit more anterior, all right? So I know that at the end, when I look at the fellow eye, that the lens is set much deeper, he's got a deeper AC in a pseudophakic eye, I would actually correct for that. Okay, so I will adjust the IOL power. But if you're having a trifocal lens where you need that great precision, unless prepared to actually, do some refractive procedure to touch up, which I wouldn't really want to do, when these eyes are so complex, especially if they had trauma and so on. I wouldn't use a trifocal lens, and the only option in terms of presbyopic correction would be an EDOF lens, because as we know, there's a certain depth in that focus. And so even if you're a bit off, you may lose a bit of the ability of having that depth, with that lens, because you're off a little on the refractive target. But still the patient will be able to have a certain amount of depth and good vision. So like that patient that I showed you, he was actually 6.6 at 5.
Thank you so
Thank
much.
you, Professor Chi.
Toric lenses, I think, are no problem. I do them routinely.
So I have a
Sergio, can
question.
you hear us? Sergio, can you hear us? I think he cannot hear us. Okay, I have a question to Dr. Vasavada, Professor Chi, whoever is using flex, that Sergio was saying that, if the lens is too posteriorly placed, subluxated too much posteriorly, you can use catalyst, but not other platforms. Lens text. What is the basic difference? And
I'm not aware, I don't have a catalyst, but I don't think there is a major difference in any platforms. There are two issues of flex, and I don't use that very much. The question is that flex can be used when there is a minimal subluxation or not much, with no tilt and not very deep. These are the eyes where you can do manual rexus very well. So you really don't need it. But this is the eye where flex will help. The eyes where we really need the help of flex, where the lenses are very deep or tilted, that doesn't work. So although the flex is a great idea, and spherophakia is one example where you can very easily do it because there is no zonules all around it, anterior place. That's the only good indication for flex. But otherwise, flex is not going to make a hell of a difference in the eyes where you can perform. Because in those same eyes, you will be able to perform the manual. So I've done quite a few flex, but it is more for my interest rather than actual really a help,
So I have a question to Basavada, sir. Sir, if the capsule cannot preserve, so the preferred technique is removal of the cataract, then fixations the IOL either in the anterior chamber and posterior chamber. Recently, there is a webinar in the WOC, and Professor Shi, David Chang also was there. And there's an audience question was there, and 46% audience, they respond, iris claw lens that we had already discussed. The only issue is the phacodonesis. And that is not only the children, in the adult also. 20% people, they respond ACIOL. The main problem there is, well, the IOL is a close proximity to the corneal endothelium that might cause the endothelial decomposition, and the size also issue, otherwise it can cause glaucoma. And 20% audience, they respond scleral fixations with the sutures, especially Gore-Tex sutures. That is also my preferred technique. I have experience only that one. And only 6% audience, they respond to any form of intrascleral haptic fixations, whatever may be glued IOL, EMNet technique, modified EMNet technique, or 4-planche technique. The Sergio, what he has shown, it is a very impressive, highly impressive. I am also looking forward to do this if I get chance in futures. So what is your opinion regarding all these things?
I think the things are changing as we learn more and more, as we acquire more skill and some more data. This profile is changing in some parts more than the others. Iris claw probably is more popular in the European region than it is in Asia. So from my point of view, what I see is that either the transscleral fixation with the Gore-Tex or intrascleral with the Yamani or glued technique are the two fairly increasing in their incidence. But it is really individual experience in the training.
Sir, do you think that multi-piece IOL will be give additional support to the capsular tension device than the single-piece IOL?
No, I don't think so, but I can value others' opinion. I don't think single piece or 3-piece is going to make that much of a difference. Single piece probably will be more stable and will require a smaller incision. You can use whatever it's not a big difference.
So do you think that Marfan syndrome with progressive zonulopathy, the longevity is the issue
Yes,
So
2-point
preservation
fixation.
of the
You need
preservation
a
of the
2-point
capsule.
fixation, 2-point fixation, and a 5060 proline with flange or a Gore-Tex.
One thing I think anterior chamber lens should not be given because
Correct.
there are a lot of complication of the anterior chamber lenses.
I think that's a consensus. But Marie-José, please.
Yeah,
No,
please.
I agree. I agree.
I
I
agree.
completely agree. Anterior chamber lenses, no. I don't think that you can ever put that in a person of 20, because we are dealing, most of the cases we are dealing with young people. So no, I don't think that this is an option. Okay, from time to time you can have good results, a good outcome, but it's not because you have from time to time that you have a good result that this is a good lens. So no, that is not possible. I think that Iris Glow is still a valuable lens, but of course it is, the problem is that you need 5.5 millimeter of incision size, which is relatively large. If you use it very carefully and you put it as much as possible posteriorly and you make your cut at the level of the limbus, really limbus, scleral limbus, then your effect on the astigmatism will be relatively good. But you have always the healing time that takes approximately four weeks, that the patients do have a big astigmatism for a couple of weeks. And that is not so pleasant. After that, as soon as you can retrieve the stitches, everything comes in order. But okay, now again, and I say it again, if we want to know, we need to have multicentric studies, because also that to put some lenses, scleral fixated lenses, use toric lens, use artisan lenses, Yamani technique, modified technique, and so many other techniques are coming up. In order to know which one will give the best results, you have to do it multicentric. We have to work on that. And I think that there is also a project that is going on at the ESCRS to get answers on that kind of surgical approaches.
I have a question to Professor Chi and Dr. Vasavada. Sure, Professor Tazignan is not familiar with yak cap anymore. Now, if we put a CTR and all these things, we are retracting the capsule. If we do yak, is there a possibility that it's going to split from end to end?
No.
Any extra care for that?
No, nothing. You don't need to worry about it. It will behave like a normal bag.
But you don't do it immediately. It might happen that you can have that immediately after surgery. But if you wait a couple of weeks, then you have such a fibrotic reaction that everything will be kept. Everything is glued with each other. Don't forget that. The remaining lens epithelial cells will proliferate and will proliferate everything together like one big entity, one big mass, in fact. No, then you don't have to be afraid for that.
Actually, the procedure that I would fear more is actually doing a posterior capsulorhexis. But we've seen it being done tonight, and I've done it also even in a 2-year-old, because I was doing it in Myanmar, and if I send the patient back to the village, that little child will not be able to see. So even after putting in a CTR, which was the standard size, all right, 12 mm, right, we talked about the different sizes, it was a plain CTR, I still did a posterior capsulorhexis safely. So I think that isn't a problem doing a yak capsulotomy at all, because you can do a PCCC safely at the time of surgery with the CTR in.
Sergio, I think we have a question. Is that the size of the CTR you have said, you put small CTR for children. How do you decide? On table, or you calculate anything pre of doing ASOCT or UBM?
Right.
Yes, the white. Sorry?
The size of the CTR, you said that, in small eyes, you put CTR of 8 millimeters. How do you decide? On table, or you do any preoperative test?
I personally use a small CTR.
I decide.
That's for all children. because for me the CTR is not absolutely, it's just to keep the capsular bag open during the surgery, because as such, the CTR is not capable to keep the capsular bag open. It will react, the lens epithelial cells of the equator will react on the CTR presence in the angle, will encapsulate it, it will shrink, and you will have, anyway, you will have quite a big, a relatively quite important contraction. So for me, it is not the CTR size that is important, except to put it, you cannot put a big, but the smallest one that is available is the one that is my standard CTR.
I thank everyone, all the speakers, that it was a great session, a great learning for all of us. I would like to invite Dr. Mahabaraman Chaudhary, Chairman of Bangladesh Eye Hospital, to have his comment and end today's session.
Just before that one, I would like to thank Dr. Ishtiaq Anwar for arranging such a great webinar, and it was very much helpful to us. I have my gratitude and thanks to Dr. Ishtiaq Anwar. Dr. Mahabaraman Chaudhary, please.
Yeah, Dr. Ishtiaq, you have done a wonderful job. Congratulations to you and all our speakers. You have been a master in your presentation, and the technique that you have shown was really an artistic way of dealing with science. And we really appreciate this, and probably we'll be looking forward to meet you and listen to you and learn from you in the future. And special thanks to my guru, Dr. Vasavada. It's been a pleasure and honor always to learn from him, and that's what we have been doing for years together. So this has been an excellent session, and I thank Ishtiaq and all the presenters again, and ends today's program. Thank you very much.
Yeah. Thank you, everyone.
Thank you so much.
Thank you. Thank you. Bye-bye.
Thank
Bye-bye.
you.
Thank you.
Thank
Thank you.
Well done, everybody.
Thank you.
Sir,
Thank you.
namaskar, sir.
Thank you.
Thank you. Thank you, sir.